Good morning, everyone. We're just waiting for Anthony to join. We'll be starting shortly.
I'm
Waiting
here,
for
Christina.
people to join. Oh, okay, Anthony.
Have we got is Sean with us? That's what I was just checking.
Sean was just here on the briefing call, so
Yes, Anthony, I am here.
That's great.
So many people, it's hard to see.
Yeah. So welcome everybody. This is the second one of our webinars, our Respiratory Matter webinars, and we're going to be running a series of these through the year. We're using this as a space to sort of bring people together, update people on the work that's happening, sharing good practice, and hopefully giving you some things you can take back into your day job to share with colleagues as who can't join us today. I've been given some housekeeping rules to ask you all to follow by, which is if we can keep our microphones muted and cameras off. If people have got questions or comments, if you post them in the chat, and we will use the time at the end to answer any of those that we can. The session will be recorded, and then we will put it on our the Respiratory Network website and SharePoint. The links for those will be within the chat. So what I'm going to do now is introduce our speaker today, who's Sean Evans, who's a consultant in public health in the primary care division at Public Health Wales. I've got that right, Sean, haven't I? Yeah. So Sean is chair of the National Task and Finish Group on Inhaler Decarbonisation, Use and Disposal, and been working closely with us in the network and colleagues across Wales to improve our green prescribing. So Sean's going to be walking through how we've been progressing on prescribing our more environmentally sustainable inhalers in Wales, look at our prescribing trends here in Wales and comparing with the rest of the United Kingdom, how they've aligned with national clinical guidelines, a little bit on inhaler recycling schemes, and then a little bit around the emerging developments in some of the propellant gas technology, which will probably be really helpful for some of you because you'll have a lot of drugs rep knocking on your doors over the next few months. So to give you the little bit of heads up on that, I think will be really good. So once Sean's finished, we'll pick up some questions, time dependent, and then we will collect a Q&A summary sheet and share that following the webinar. So I'm going to do what I've been told to do now, turn my camera off and my mic off and hand over to Sean. Thanks so much, Sean.
Thanks, Anthony. So before I start, I just wanted to say I'm by no means a clinical expert in this field, and it's quite daunting to see how many clinicians I have on the call. So please correct me if I say anything that's incorrect clinically. However, I am a pharmacist by background, and I am still registered as a pharmacist, although I don't practice as a pharmacist. So this is very much close to my heart because it's the medicines agenda. I've got some slides. I'm going to go through them. I'm not going to go through all the detail. I'm happy to pick anything up afterwards. And there's lots of links on the slides that will be posted in the chat as we go through. The slides will take about 20 minutes, 25 minutes, so we'll hopefully have enough time for questions and answers. So I'm hoping this will work, and I will share the slides, which means I won't be able to see anybody. So if somebody can give me the nod when that is the case.
I'll let you know when they're up, Sean.
Okay, so I don't think that's being shared. Let me just share them.
Bear with us. I think Sean's pressed the exit meeting button rather than the share button. She'll be back with us in a second now.
That's a good start. I pressed the leave button instead of the share button. Okay. I think my nerves are getting the better of me, so please forgive me. Right. Okay.
Oh, we can see your screen now, Sean.
Thank you. Right. Can you see that in full screen now?
Yes, thanks.
Fab. Okay. Right then, so we've called it Going Green. I'd like you to be able to go away today to just have a little taste of an understanding of the positive news story that I'm going to share with you, and some of the areas that we're still looking at, and have some confidence that we're not ignoring it, even though some things are taking a little bit more time. And actually congratulate yourself on the hard work that's been done in what I would consider a very short period of time. I've been in the world of prescribing for quite a long time. I was one of those practice pharmacists who used to knock on doors of GP practices and tell them what they're doing wrong. And sometimes it takes years and years and years to see a shift. But I think this is a real positive, accelerated shift that we're seeing for a whole host of reasons that I'll hopefully be able to share with you today. So I just thought it was important to set the scene around when we're talking about asthma or COPD or respiratory, the number of patients involved in Wales. I've got this data directly from the Asthma and Lung UK web pages, and what they are saying is that in Wales we've got nearly 600,000 patients receiving treatment for asthma. Now I say that because they're not all diagnosed. That's really important when we come to what you need to do next. And then about 200,000 with COPD. So loads and loads and loads of patients. That culminates in about 4 million prescriptions a year and £80 million. So there's a reason we're interested in this, because it's really big. But actually, when we're talking about changes, we're talking about individual patient changes. So I really applaud all the practices out there and our secondary care colleagues and anybody that's been doing hard work, because this is no mean feat. You know, we're talking about lots and lots of interventions to see the success that I'll share with you in a bit. So well done, everybody. Okay. I'm going to just give you a little bit of a taster for those who are less au fait with what we mean by carbon footprint, so you can understand why we're interested in inhalers. So in 2018 and 19, there was an exercise undertaken, commissioned by Welsh Government, where a carbon footprint of NHS Wales was done. And at that time, this report published that over 1 million tonnes of CO2e, which I will explain what that is in a bit, was attributed to NHS Wales. When we looked at this work in Public Health Wales, we then revealed that this is just in secondary care, this is just hospital settings, and there's a whole chunk of work that we know happens in primary care, and particularly around prescribing. What this report identified, and there was similar reports done in England and Scotland at the same time, and the pattern is all the same, is that drugs and pharmaceuticals is a big chunk of the carbon footprint. And within that, inhalers accounted for a lot of the carbon footprint, which is why there was a focus on inhalers at the time. So that report told us that in hospitals, there was 30,000 tonnes of CO2e. And I've worked out from data that we've got that at the same time, there was about 65 tonnes within primary care, so almost twice as much. So across NHS Wales, it's about 95,000 tonnes. What does that mean? So if we actually look at the equivalents, we're talking about 250 million miles in a petrol car. So this is the reason why we decided to look at inhalers, and why we felt that it was important to set up a task and finish group to try and address some of this that we know is contributing towards the carbon footprint. The narrative underneath the blue inhaler that you can see there is what we mean by a carbon dioxide equivalent. So I do a little bit of teaching sometimes, and I go out and I speak to GPs, and this is language we use all the time, but I just thought it's important so that people understand what we mean. And really it's just a metric that allows us to standardize when we're looking at different devices, different medicines. So a carbon dioxide equivalent, the proper term or definition is the amount of carbon dioxide that would have the same impact over a 100-year period. So it just allows us to standardize it. And to put that in context, an average petrol car on the road in the UK produces about 180 grams of CO2 every kilometre, and we've got 95,000 tonnes just attributed to inhalers in 2018 and 19. So the All Wales Therapeutics and Toxicology Centre produce reports every month. The links there, which will be shared, is where you can access them. And they've been mapping this for some time, so it's really helpful to have that data. Anybody on the call about a month ago where Arthur did the showed the dashboard, and this all links into the work of the dashboard as well. So that's another way you can identify some of this. But what it showed us is that when we started looking at this work, April 2019, the baseline was about 65,000 tonnes of carbon dioxide as a result of inhalers. That's just primary care data. And what we do know at the time is about 2% of those inhalers were prescribed as what we call the lower global warming potential inhalers. That's what we class as the green inhalers, the dry powder inhalers. And over our efforts, over a period of time, as you can see during COVID, obviously there was an increase in inhaler use, but it's gradually come down, and it's come down quite steep since 2022. And we're now around 43% of inhalers are prescribed as what we call our lower global warming inhalers. That's taken from the same report, is published every month. And what it shows us is how we compare to the previous 3-month period and then the same time the year before. And generally, what it's just showing is that the carbon footprint is coming down. That's as a result of the MDI. So monitored dosage inhalers, they're the old-fashioned blue inhalers with aerosols, not old-fashioned because they're still available, but the ones that we would like people to be reviewed on. So that's coming down, and as a result, the carbon dioxide associated with that is coming down, and there's an increase in the use of these dry powder inhalers, which is fantastic to see. So taken from AWTTC again, through the Spira dashboards, you can actually see what that means for Wales as a whole and for individual health boards. This data is standardised per 1,000 patients. So even though we've got Cardiff and Vale sort of at the bottom and then Pepsi at the top, it shows the amount of carbon related to inhaler use across the health boards. The line is steadily coming down. There's a slight blip, which is starting to increase by just 1 point in April. So we do need to keep an eye on what's causing that and to see whether that continues to increase. But generally, trend is in the right direction. And for me, what's interesting, and we haven't unpacked that yet, is the variation between health boards. And I think that's something that we need to start considering as part of the task and finish group then, and how we share the good practice of those that manage to achieve a greater decline, beg your pardon. So I'm going to now talk, this is me, this is what was in my head being put into a slide around what I think has contributed towards that downward trend. So I'm sure there are some I've missed. If anybody's got any examples of something that they think has really caused that trend, local or national, please feed it in, because I think this is something we're going to try and start to collect and piece together now. But there's been a lot of work nationally around lots and lots of things over the last couple of years of what could contribute towards that change. So we have policy and strategy through the delivery plan. We've had targets, the clinical network, and all the work that's come out of that is definitely a driver for this. We've got the guidelines written by the network, endorsed by AWMSG. We've had projects being funded, it's been included in contracts. We've got indicators, ScriptBridge, health pathways, the scheme that we support, our Greener Primary Care Wales. We've got a strategy for inhalers. We've got task and finish group, and now there's a MHRA safety warning, which I'll talk about later. But we do know this thing's been going on locally. We haven't really unpacked what that is, but that's something over the next couple of months we're going to be reaching out to health boards to find out whether some of these local initiatives is what driven the change locally. And we've got a whole range of tools to support the monitoring of that and practices to see where they are. So I've included those there. Okay, I don't know how well you can see this because the writing is quite small. However, what I've tried to do is map back, what's been happening, and it's almost like the journey. So it was every time I do something like this, I learn something. So apparently COP1, which we all know about COP, was in 1995. So we've been at this for quite some time. And so the things below the line are more of the kind of international, global drivers for this. Then we've got the grey areas above the line, which is what I consider is Welsh Government policy, and the thing that's driven some of that, such as the Wellbeing of Future Generations Act, the climate emergency that was declared. And then we've got what I consider these sort of paler turquoisey blue, which are more like enabling functions, whether it's the strategic delivery plan, we've got all the guidelines there, we've got contracts, so all the things that I listed earlier as national drivers, because I thought it's quite helpful to see when these things came out and actually what impact they're having. So the guidelines were written, first one in 2019 for COPD, written by the network, went through the All Wales Medicine Strategy Group system and process, endorsed, which means that these are like nice guidelines. Health boards should be implementing them and should be measuring against them. So we're fantastic in Wales. We've got 3 different guidelines that have been published over 3 years, all credit to the network and the individuals in that network and clinicians writing them. We meet quite often with our 4 Nation colleagues. Scotland are looking at our guidelines and basically following them and, you know, using their own, the opposite of dragonflying them. I don't know what they would do in Scotland, but they're looking at ours and adopting them. England have got nice guidelines, obviously, now, but before that time, they were looking to us. They were very envious about the fact that we have these guidelines in Wales. And I think that's a massive contributing factor to sort of starting that conversation, the discussion around the changes for inhalers. Many people who are familiar with the guidance, I've just pulled out one, which is the asthma management guidelines. There's a great one-pager in each of these that basically talks you through, you know, the inhalers of choice. It all features and aligns with everything I'm telling you today. I've shared these because I wanted to give confidence into the system that these guidelines, although published, are regularly updated. So the authors that wrote them are consulted and they go back through the All Wales Medicine Strategy Group. And the asthma guidelines in particular has gone through a number of rounds because there's been some changes over the years with asthma prescribing and where the products are placed in the guidelines. So the one message today, which I will reinforce, is if you're not sure, just follow the guidelines because they're as current and up to date as they can be. Okay. We were lucky in Wales. We had a strategic delivery plan that was published in 2021. And within that plan, there were 3 initiatives related to inhalers. The first initiative, number 42, was around the over-reliance of the reliever inhalers, what we know as the SABRA inhalers. They're the blue type inhalers that everybody seems to carry around in their bag, in the school, etc., etc. Then initiative 43 was around the product choice and trying to switch to a less carbon intensive inhaler. And then initiative 46 was around the disposal of inhalers, and I'm going to cover all of those today. So this gave us a bit of a roadmap and a remit to think around how were we going to deliver against the strategic delivery plan. So as a result of that, we developed a task and finish group. Anthony is a member of the task and finish group, and Simon Barrow before Anthony was a member of the task and finish group. It's got a wide range of representatives. I'm very happy to share the terms of reference. It's not necessarily exclusive, but we do try and keep it quite tight. We've got Asthma and Lung UK on it, we've got the ABPI on it, and we've got a whole range of other individuals at the task and finish group. One of the first things the Task and Finish group did was endorse this national strategy for Wales that really focused on inhalers and what we were going to do. That's available on the AWTC web pages. And this is how we organise ourselves. We've got the main group, and then we've got a couple of subgroups, because what we found is that we were discussing lots and lots of things at that main group, whereas really we needed to get into the nitty-gritty. So we've got a subgroup that talks around communication and engagement, and we're now in the process of looking around what leaflets, posters, etc. is available for practitioners to use with their patients, but also for patients directly. We've got a group looking at inhaler disposal, and then we've got this 4 Nations group, which is where we touch base with our other counterparts, which has proven really useful. So we're not all duplicating efforts when we're talking to people like the industry. Okay, many of you who are prescribers hopefully have seen this. So there was a warning published by the MHRA, which is the Medical and Healthcare Regulatory Authority, in April 2025. And the timing is perfect, really, because it was basically reinforcing what we've been saying all along, which is that people or patients who are on only the blue inhalers for asthma of any age really shouldn't be on just a blue inhaler on its own. It calls for an urgent review, and then it calls for those patients to be also prescribed something which we call an anti-inflammatory inhaler to be able to manage their asthma. And there's reasons behind that, and it's because it can mask progression of the underlying disease, and actually we know it has, as a result of people only having the blue inhalers, there's potentially life-threatening asthma exacerbations. So if you weren't hearing it from the network or from the Task and Finish group or from your local prescribing teams, the MHRA safety warning is there to say, we really shouldn't be just prescribing the blue inhalers anymore. Okay, so this is the bit I like. So this is the bit all around how we're doing, and this is the good news stories. So this graph demonstrates all health boards and total inhaler prescribing items by health board since 2021. What it shows is that there's little change, really. And I think that's important when we look at other prescribing for other chronic conditions. So if we look at diabetes, we look at a lot of them, the number of items of prescribing is increasing exponentially, and yet for respiratory it's remaining stagnant. So when we then look at the changes in a minute, it's because we are supplementing different products, not necessarily prescribing more, which is a good news story. The variation you can see there across the health boards, and that'll be consistent with all the graphs I'm going to show you in a minute. So this graph shows the dry powder inhalers use as a percentage of all inhalers. And what it generally shows, the big blue line is the Wales average. It shows that we are increasing, as you would expect, because of the efforts that's happening. And we're prescribing more and more dry powder inhalers and switching from those more aerosol related inhalers to the dry powder inhalers. Again, the variation across health boards, you will see it'll be the same health boards who are sort of towards the top and seem to be really championing this, and then the other health boards who are maybe a little bit slower in doing this work. But we need to look at the variation and need to look at what's happening. So I'll shout out for Hywel Dda here because they are towards the top and keeping their position towards the top. And I do know there's some work going to happen in the next couple of months to identify what's happening in Hywel Dda and whether we could share and spread that practice. I've included 2 points on this graph where the GMS contract included this as part of the contract, because I think that was a significant shift that did help to influence this change and provide an incentive for practices to look at it. So similarly, for the SABA inhalers, so those short-acting beta agonists, the blue inhalers, the message is to be reviewing those for people to not be on them on their own. And you can see there is a drop in use of these SABA inhalers. And again, it's a mirror image of the graph before, and we've got Hywel Dda again sort of almost standing out compared to some of the other health boards, but the decline is in the right direction. Okay, the information is also available by cluster and by practice. All this is available for anybody in the NHS through the All Wales AWTTC data dashboard through Spira, but I've just given a couple of examples to just show what the variation is. So the graph at the top is again the dry powder inhalers as a percentage of total items, and it's every cluster across Wales. So you can see, even taking Hywel Dda, the red, there's variation across the clusters in Hywel Dda, but when we look at all the clusters, so obviously the highest is the cluster at the top here, the red one, and that's 62%, but then we've got ones at the bottom that are only on 34% of dry powder inhalers. So that variation is quite stark. We might need to look at that and think about how we can try and bring the ones at the bottom maybe a bit higher if we're to reach our target. And then when we're looking at practices, which is the graph at the bottom, the practice variation is even more stark. We've got some practices at 84% dry powder inhaler prescribing, and then some still at 19%. So again, that variation probably needs looking at, unpacking and challenging to a certain extent if we're advising people to follow the guidelines. So these are new graphs that have been sent to me from the All Wales Therapeutics Toxicology Centre. And so the new guidelines are very much around maintenance and reliever therapy as a combination, and that's what we want people or patients to be using. And you can just see the orange graph shows those short-acting beta agonist inhalers alone, whereas the blue is the combination inhalers, and you can see they're starting to cross now. So we're actually getting the message out there, and people are starting to go onto the MARP therapy as opposed to SABA alone. And the same for the second graph, you can see they're converging. The red line shows when we felt that converge started, and I think that is probably related to the guidelines that was advising people to use them. Okay, so Anthony said that we do look across England, Scotland and Northern Ireland, and we do meet with them regularly. And we do try and monitor what we're all doing, share and learn from our practices. And from the very beginning, Wales was standing out as slightly different. The graph, which you can't read any of the axes for, so forgive me for that, but the graph that says UK variation, Wales is in pink, and it shows that there was something different happening in Wales at the time. It is slightly old. That's because the data wasn't routine and we had to request the data from particularly Scotland and Ireland in order to draw that graph. But it does show that Wales was doing something different, or the impact of the efforts in Wales was different to elsewhere across the UK. What we can monitor on a more regular basis is how we compare to England, because that data is open source data and it's more routinely available. And Wales is in red. So again, when we're looking at the dry powder inhalers, you can see that in Wales, we are doing something slightly different to England, or maybe we're just accelerating the work, and we monitor this on a regular basis with our colleagues across England, Scotland and Ireland. So I'm going to just pick up on two areas. I called it areas to keep an eye on because I haven't got all the answers, but I do know it's probably the things that cause most questions. So one is going to be about inhaler disposal and recycling, which I'm going to share with you what I believe I know. And the second is the new generation propellants. So we have got a inhaler subgroup that looks at the disposal and recycling, which is where some of this information is coming from. And it's through the Four Nations work that we've got the intelligence around the new generation propellants. So starting with the first, inhaler disposal and recycling, I'm going to be up front here. We do not have a national scheme in Wales, but we are working on it. But there are a couple of complications or issues which make it a little bit more complex. First of all, when we think about inhaler recycling and actually think about the footprint of inhalers, the recycling bit of it is just a really small proportion of the footprint. And we've got to be clear about what efforts is needed to just release that small amount of carbon compared to the work around trying to get people on the right inhalers in the first instance. So there is something about proportionality there. Nevertheless, it is being looked at. The newer devices that we're encouraging people to be moved on to, such as the dry powder inhalers, have got lots of mixed materials, mixed plastics, they've got metals, they've got springs, they've got lots of things in them. And some work that was carried out in Cwmtaf showed that disassembling them and recycling them makes it really difficult. So it's not just a case of chucking the whole lot in a bin and recycling it. It does take a lot of effort. So that's something that needs to be factored in. It's not just the plastic, it's the metal and the propellant. And there's only one company in the UK that promotes that they can do this currently. So this is still in a very kind of new world of waste management. And we have had a number of pilots that's been underway. One that happened in Swansea that England have now taken and have done slightly different connotations to that. So we're trying to learn from these pilots to see what can happen to inform an inhaler scheme in Wales. But we are working with shared services, I say we, the Task and Finish group in the system, and the waste contract for Wales is up for renewal in 2027. And there are discussions at the moment underway with waste contractors to see how they can build this into their normal waste management. So be rest assured that hopefully when that contract is renewed in 2027, there will be something in there around inhaler recycling. But in the interim, the key message is that any medicine, inhalers, tablets, anything, should be returned to the pharmacy, whether it's a hospital pharmacy or whether it's a community pharmacy for safe disposal. And yes, at the moment they get incinerated, but if we can encourage patients to return them to community pharmacies and to hospital pharmacies, when the national scheme becomes available, that behaviour change of patients should already hopefully be entrenched. And the little picture or poster you see there is available from the Welsh Government Communications Media Toolkit that can be downloaded and displayed in any practice. That's not new, that's been around for some time. So that's inhaler disposals. And this new generation propellants, which is fantastic that it's happening, but it is giving me a little bit of a headache trying to keep up with what's going on. And I know we've got some colleagues on the call who probably know more than I'm going to tell you now, so we can pull them in if there's any questions. So the pharmaceutical companies have been working on this for some time. But in May 2025, so only last month, the first new generation propellant was approved by the MHRA. It was a AstraZeneca product, and it was for their project Trixio Aerospace. What the drug company tell us is expected to come to market in the next couple of months. So they're aiming for it to be available in September 2025. The product they've chosen to use for this new generation propellant is a triple combination inhaler for adults with moderate to severe COPD, which is an interesting choice, why they've chosen that one. I'll say no more about that. But it uses this propellant that I don't understand what it is, but apparently it's a new greener propellant, and it's being promoted as being as safe and effective as the previous versions. But more importantly, the AstraZeneca is saying it's coming in at the same price. They're not going to inflate the costs of this new product. It's cited to be comparable in footprint to the DPIs and 99.9% lower than the MDI version, which is currently available. And what they tell us is for a period of 6 weeks to September, both the old inhaler with the non-green propellant and the new inhaler with the green propellant will be in circulation. So there'll be about a 6-week period while patients may have one or the other or both. And depending on when they pick their prescription up, they could end up having one month and another month. And we're working with the 4 nations to try and get as much intelligence ahead of this being available so we can push that out to practices. So the good news is that this particular inhaler is already included in the COPD guidelines. It's already there. It's already there as the MDI inhaler. So it's the high carbon inhaler, and AWMSG are looking at this and keeping abreast of it. So as soon as the new one is available, then this guideline will be updated. I've done just a little bit of kind of looking at prescribing data there. And at the moment, the volume of prescribing for this inhaler compared to the equivalents in that box is relatively low. And we'll keep a track on that to see how that changes with time with the new generation propellants. So we're not advocating changing anybody from the existing dry powder inhalers onto this, but patients who are already on Trixio Aerospace may benefit from moving on. Well, they won't be moving because they have no choice onto the new propellant inhalers. And the key message for us here is it's in the guidelines already. There's a system to review those guidelines. So if you follow the guidelines, you won't go far wrong. And hopefully that will be the case for any other new generation propellants that come on board. So finally for me, and that was a stop tour, the key messages and priorities for, this is coming from me, this is what I'd be saying to you, but actually this is really important because these are key messages that we across the 4 nations are saying are important. So it's looking at the over-reliance of the SABA inhalers. So that's, again, we need to be doing medicines review. We need to be confirming that these patients are actually asthmatic and they really do need an inhaler. And we've got that MHRA warning to follow then around the dangers of still prescribing lots and lots of SABA inhalers alone. Follow the guidelines. We're very fortunate to have them in Wales. They're current, they're updated, and they do promote the use of MARTs. And any new propellants will be placed within these guidelines. So rest assured that we have a system to be able to do that. The greener devices we want to promote. So yes, look at using DPIs compared to MDIs. I think this is really important. Don't wait for the new greener propellants because anecdotally, we've been informed that some practices are being advised by a whole range of different people to not do the switches now and to wait until the new greener propellants come out. We don't know when the other ones are coming. So any efforts to reach that target, we need to carry on with the DPI switches. Again, follow the guidelines and advise patients to return any inhalers to their pharmacy for safe disposal. And I think that's it. Very happy to be contacted directly if anybody wants any more details around the task and finish group or our efforts. And we can just take some questions. So hopefully that'll be more interesting than I just told you. So I'm going to end this slideshow and hope I don't, there we go, leave the call. Thank you all.
Brilliant. Thank you so much, Sian. Thank you for that. And I think that was a really a great tour through, but I don't think necessarily encompasses the amount of work that's been put in by yourself and everybody on the who's been doing that work. So I think it's huge, and I think what's lovely to see is the data that demonstrates the change, which I think is really, really important. And I suppose the message around this is that the reason this is important is it's not making the switches and making the move is not just this is not just environmental. There is a clinical reason behind it as well. And we all know on this call that high SABA use is a real risk factor in that subgroup of patients. So there is a clinical reason for doing this as well. So and yeah, in terms of the new propellants that are coming, I think it shouldn't stop us doing any of the reviews at all on that clinical basis. So massive thank you. I'm in a second. I'm just going to go give people a few minutes if they want to put any questions in the chat bar that we can run through. I haven't seen any questions come up yet. I think, Sean, you've obviously covered everything, and there's what's in there is some really we've put all the links in the dashboard in the sidebar, sorry, in the chat bar for everyone who wants to go in and have a look at the links to the various dashboards, and if they want to pull out the data for their own practice, their own cluster, their own health board. It's worth, when you've got, I know we don't all have a huge spare amount of time, but worth just going in and looking what's happening around you. It's quite enlightening. The variation in practice. So I think that's been really helpful. Just some comments around saying enjoyed the overview and of the work going on. So that's been really helpful. Sean, I do want to say a massive thank you for you giving up the time and coming and giving that talk. It's a very weird format to do it, isn't it, when you've just got loads of screens and you can't see people's faces and that sort of thing. So it is very strange. So I do thank you for that. And as I say, this will go up on the Respiratory website for anyone who hasn't been able to make it, or if there's colleagues you'd want to share this with across the patch. Our next session is in July, on the 17th of July, same time, 12:30, and we've got two of the people coming from NRAP, which is the National Respiratory Audit Programme, to come in and talk about the primary and secondary care work streams, the data, etc., etc. So, and I know a lot of you contribute to that, so it's a really good session to be able to feed back to everyone. And so that was that. The other thing is that if people want a certificate of attendance for their CPD or portfolios, if you just email the shared mailbox, we can get one across to say that you've attended this. So you can put that in your portfolio. Sean, was there something you wanted to...
I just wanted to put an offer out there. It does take a little bit of effort to put those graphs together, even if you are familiar with Spira. And we do have a lot of them so if anybody wants anything specific, that I'm happy to share it and send it to people if they wanted to have those conversations locally, and to just have the graphs to say, look, where are we? What's the variation? So don't feel you've got to reinvent the wheel. Just contact me and I can send you what we've already got. I won't be running new ones, but you're very welcome to have what I've sent, and we've got more than that, to help tell the story locally if you wanted to have those local discussions. So if you email me directly, I can share anything that you've seen today.
Sean, that's really great, really helpful, and I hope people take you up on that offer, because it's really helpful to share that with your local teams, and always makes people go away and do a bit of thinking about their practice. So I've not had any other questions through. Loads of compliments, Sean, so thank you for that. But apart from that, I'm going to thank Sean once again for giving up her time, not just to present it, but pull the presentation together. As we all know, that it's a lot of work. So massive thank you to everybody. And we will see you at the next one on the 17th of July. So massive thank you.